Assalamu alaikum. Honorable chairpersons, panelists, and learned audience. Last day, last session, but newer things in the sense that this is for the first time Bangladesh Society of Cardiovascular Intervention done a joint session with any other organization of the country, and that is Bifurcation Club. And in that session, we must welcome to the President, Secretary, and the organizers of Bifurcation Club. Let us see at the end of the day, this is a very tough topics or a dry topics. Even then, we want to make a bit palatable. Current LM bifurcation treatment strategy, how to select the best option. I tell all the time that if you have 3 roads to go from Sonargaon to Evercare Hospital, then none is ideal. Somebody likes road A, somebody likes road B, somebody likes road C, and may have road A some advantage that road is free of rickshaw, and somebody likes another road, that road devoid of bus, so private car can go easily, and some road may be only for car easier, but occasionally some big cars always come. And that is why I tell that this is a very crucial chapter, that is to select the best option. However, whatever in our hand, with that we want to select. This is the fact all of us we know. The left main disease 30% approximately osteal and mid shaft lesion, and distal left main approximately 70% lesion, and you see restenosis rate approximately 5%, and distal, if it is distal, then approximately 10%, target lesion revascularization rate less than 10% sometimes, and lower rate of success for distal left main, but higher rate of restenosis. And these are the different classification, all of you know. Factors deciding strategy for LCX. As because there is bifurcation LM, so first of all we know regarding the LCX, size of the LCX, if it is totally occluded, forget about it, no matter. If it is less than 2.5 millimeter, try to protect with a wire. And if it is large, then analyze plug distribution, calcification, bifurcation angle, diameter of LED, LCX, and accordingly you may decide to have only protection wire, gelled balloon wire, gelled balloon and professional stenting, and 2 stent techniques. The modern approach to bifurcation LM interventions, stepwise evaluation, bifurcation lesions, severity of the stenosis and plug distribution, clinical relevance, prognostic relevance. And clinically relevant vessel treatment could be translated in relief of symptoms and ischemia, improvements of prognosis, and prevents MI and different types of arrhythmia. LM bifurcation side branch many a time is a main vessel. Evaluation of the stenting strategies, if we know the bifurcation strategies, how it evaluated, started in 1984, there was only kissing balloon coronary angioplasty, 1986, only balloon angioplasty, and 1985, techniques for Palmas-Shah's stent deployment in lesion with large side branch, first started in 1995, and provisional T-stent strategy also in 1996. In 1996, from kissing balloon to complex stenting, T-stenting. This is 1996, and from kissing balloon to complex stenting culotte, this is 1998, and at the same time, in the same year, kissing balloon to complex stenting, V stenting, 1998, and kissing to complex stenting, meaning crash stenting in 2003. And huge amount of data coming from bench testing was acquired in the last 15 years, guiding us to improve and optimize all strategies in bifurcation lesion interventions, both simple as well as complex. Not only the bench testing, but also intravascular imaging for LM daily in LM lesions in daily clinical practice. And intravascular ultrasound imaging guided versus coronary angiography, guided percutaneous coronary intervention. As you know, for left main intervention, image guiding is superior than only angiographic guided. And all different studies all in favor of image guided. Even then, in EBC main trial, you have seen that only 20% done in complex lesion, only 20 to 30% cases only imaging was done. And intracoronary imaging, there are different types of imaging, OCT, IBUS. Their evaluation is also written here since 1991. I don't want to go through it. I want to tell it only the indication, that is class 2A indication of imaging for coronary intervention. And more effective devices for calcified lesion, debulking, and vessel preparation. This is very important. You see there are different techniques in our hand, NC balloon, cutting balloon, angiosculpt, and that is not available in our hand. Shockwave lithotripsy, rota, all in our hand. At the present time, for choosing the best option, we shall have to think different platforms with different designs and more appropriate start thickness, more understanding and sharing the details of bifurcation lesion, and more use of intravascular imaging, more effective devices for calcified lesion preparation, and performing improved basic strategies and sharing experience, and more clinical data on long-term outcome coming from both sides and shared. And simple complex bifurcation lesion stenting strategy selection, simple or complex bifurcation lesion stenting selection depends on size, length, and distribution of the lesion, lesion severity and lesion length, anatomy of complexity of the side branch. And however, we do not have yet universal definition of what is complex and what is simple bifurcation lesion, but there are some consensus. EBC 16 consensus, they have shown what is bifurcation lesion, what is complex bifurcation, and what is simple bifurcation. And there are Medina classification, all of we know it, and in definition 1, 3 criteria, we also know it. And operator experience in performing and optimizing any bifurcation lesion approach is more relevant than the specific technique selection. Maybe the technique selected by the performer according to his wish, according to his experience, but his experience is very important. And different technical challenges, main determinants is the side branch. And bifurcation lesion stenting, we know what are the bifurcation lesion stenting types. It may be professional stenting, and if it is simple bifurcation, do simple stenting, that is professional stenting, and if required second stent required, professional side branch stenting will be done, professional second stent will be done, and if the side branch stent will require stenting, you may go to the crash, either mini crash, decay crash, or culotte, or T stenting, tap stenting, any of the variety you may go through according to the anatomy as well as the vessel lesion morphology. And EBC main, you see that side branch treatment was done in the left arm, that is in the professional arm. 100% they did the professional, 100% they did the KBI, but only 22% required second stent. And these are the different stepwise provisional stenting. I don't want to tell these steps, but one step I like to tell regarding pot. If no side branch some points, if no side branch compromise, no chest pain, no ECG ischemia, TIMI3 flow in side branch, procedure considered as finished. If side branch is compromised, chest pain, ECG ischemia, TIMI flow less than 3 in the side branch, and only then, if the side branch is compromised, only then we require side branch intervention. And in that side branch intervention, we do kissing balloon inflation and pot, and if necessary, second stent, and this is the final result. Still having some problem on non-stent, if you do not stand, but KBI has been done, still having some problem on non-stented branch, chest discomfort and TIMI flow is impaired, a second stent to the side branch will be considered. And these are the different steps of complex stenting, tap stenting or culotte stenting, decay crash stenting. One stent better than 2 stent for LM bifurcation stenosis. Many of the trials shown approximately 70% to 80% lesion, single stent strategy is better, except decay crash 5 trial or another decay crash trial, all in favor of single stent strategy. When 2 stent technique, provisional stenting, more than 70% what I have told, and 2 stent, that is diseased left circumflex, that is second branch, if it is diseased 111 or 101, large circ with more than 2.5 dia, and diseased left dominant coronary system, and length of the lesion equal to or more than 10 millimeter, concomitant diffuse in the downstream left circumflex disease, only then we require the second stent. And practical experience by 2-3 minutes, I like to finish. This is a patient, 55 years old, hypertensive, diabetic, non-smoker, and a history of chest pain on exertion, and was admitted in our institute, and we have done the angiogram. You see, this is the angiographic findings, and distal left main, there seems to be critical distal left main with osteal involvement, trifurcation lesion with downstream disease in the LAD. And there is insignificant downstream disease in the left circ, and we do the IVAS pullback from LAD to LM. Here LAD osteum is 3.51, but distal LM, though there is plaque burden, but area is good, 6.31. And we wired both the vessels, and we first pre-dilated the downstream disease of the LAD, and then we implant one stent from proximal LAD to mid LAD, and then we have deployed another stent across the left circumflex and post-dilated, and this is the final result. All the 3 vessels are all right, ramus as well as left circumflex. And post-stenting OCT result. You see the OCT pullback, adequately inflated the stent, and there is no malalignment, well inflated. This is another case. You see distal left main 111 involving the distal left main, and here we want to save the left circumflex as because it is a big vessel and proximal near about 5 to 10 millimeter disease from ostium, and so we have decided to do decay crash, LAD diagonal bifurcation. There is also another bifurcation, LAD diagonal bifurcation, and let us see, we pre-dilated and both the vessel pre-dilated and stenting the side branch of the LCX, keeping the balloon in the LAD, LM to LAD, and then withdrawing the wire and crash the LCX stand, and then recross once again, and then deployment of the, then first kiss done, and after first kiss, deployment of the stand from LM to LED, and port is done, and recrossing the wire into the circ. Here left panel, second kiss, and on the right panel, that is the report, final port. And this is the final result. And this is another case, you see, here distal left main involving the ostium of the left circumflex as well as osteoproximal part of the left anterior descending. As because both the vessel LED and left circumflex almost equal and angle is less than 70 degree, so we have decided to do culotte. And these are the different steps of the culotte. I don't want to tell. And I was pulled back from left circumflex to LED and here LM, and here you see distal left main, it is 5.94, and LCX ostium 3.46, and ostial LED is 3.85. And we pre-dilated both the ostium of left anterior descending and LCX. Then LM to LCX stand deployment is in progress. Some slides will obstruct, this is my luck. Anyway, opening of the side branch, recrossing and opening of the side branch, LCX start. মাত্র চালিয়ে দেখা গেল, এখন চলে না কেন? মাত্র রান করে গেছে। কে ছিল? মাত্র না রান করে দেখা দিয়ে গেল। কি হলো? একটু আগে তো সবগুলো দেখছে। ওই মেয়েটা ছিল না, একটু আগে তো দেখলা। দেখলা কেন? দেখে বললা কেন? Anyway, video is not running. পরেরগুলি রান করবে? পরেরগুলি রান করবে? আর আছে তো 3-4টা। Post dilatation left panel, though video is not running, sorry for it. Final kissing balloon inflation port of the LM. And you see the intravascular ultrasound, left main 1509, and this is finally by the hand of the Professor Ashok, it became running, it is working. And this is the final result, you see. Then do we have a gold standard strategy? 14 studies, including 4,285 patients. There are meta-analysis done in different types like crash, culotte, decay crash, mini crash, provisional stenting, T-stenting, tap stenting. What is their result? You see, here it is told that ranking system goes from 1 best treatment to 7 worst treatment. And if you see that provisional stenting, crash, decay crash, mini crash, culotte, T-stenting, tap stenting, in respect of death, cardiac death, all-cause death, cardiac death, MACE, TLR, TBR, stent thrombosis, post-procedural MI, some are 1, some are 2, some are 3, some are 4, meaning that none is ideal and it depends on its scenario. And long-term clinical outcome, as we know, PCI versus CABG, data from Syntax, Excel, and Nobel, pre-combat, all, none of them should be able to show their superiority. Excel showed their non-inferiority, and Nobel showed no superiority of intervention over CABG. But the anatomical perspective, if syntax score is less, the PCI is equal to CABG. And 10 years outcome after drug-eluting stent, there are several points. Here also in primary composite outcome, death, myocardial infarction, stroke, all in favor yeah, all in favor of CABG rather than angioplasty, except some few studies. And 10-year outcomes after drug-eluting stent versus coronary artery bypass grafting for left main coronary disease, extend follow-up pre-combat trial, that is in favor of CABG. And 10-year all-cause death after percutaneous or surgical revascularization in diabetic patients, definitely in favor of CABG. And synthes score 10-year outcome after revascularization for left main compared trial, here also shows that mortality and serious events, revascularization, low to intermediate score is in favor of PCI, and high syntax score is in favor of CABG. In summary, choosing the best for bifurcation lesion intervention, it depends on the performer as well as the anatomy and physiology of the lesions. LM disease involving both branches stent techniques should depend on individual patient's anatomical lesion characteristics and operator's skill, but professional strategy may be the best effective tool. LMPCI should be done by an experienced and appropriately equipped PCI team, and good lesion preparation is a must, and stepwise approach is also superior. Thank you all for patience hearing.